Okay, we start with a question. I will try to do my best in order to make an overview regarding the luteal phase supplementation in fresh and in frozen embryo transfer. And also I will present some data coming from my centers regarding the luteal phase supplementation in artificial cycle. Okay. So of course, this topic is very controversial. I think this is the time to talk about personalization of the luteal phase support, because in the majority of the time we speak about personalization during the ovarian stimulation. But maybe today this is the time to try to analyze the personalization in the luteal phase. Of course, the data are very controversial and so I will try to do my best. If we want to have an implantation, we need a good embryo. Good embryo means a viable embryo, euploid embryo, competent embryo, but we need a good endometrium. And the question is, what does mean good endometrium? Of course, to have a good endometrium, we need a good luteal phase supplementation. But when we analyze the luteal phase supplementation, of course, we can have some question. For example, one measurement of progesterone might reflect the real progesterone level, which is the correlation between the serum and the vaginal progesterone level. Which progesterone dose should I use for frozen and fresh embryo transfer? Which progesterone route should I use in frozen and fresh embryo transfer? When I have to start the luteal phase supplementation in fresh embryo transfer, and how long should I continue the administration of progesterone after the positive pregnancy test? So of course, this is just an example, but of course, when we analyze the luteal phase supplementation, the question is still open, and many questions we can have. I will start with a fresh embryo transfer. Of course, everybody knows that it is mandatory to use a luteal phase supplementation when we want to perform the fresh embryo transfer. According with the ESHRE guidelines, theoretically, you can use vaginal progesterone, intramuscular progesterone, subcutaneous progesterone. You have different options. And of course, the question is still open regarding which is the correct dose if we want to supplement the luteal phase and if we want to perform the fresh embryo transfer. New option is the oral progesterone, and many data is coming regarding the possibility to use this approach with a good clinical result. Of course, apparently, if you look at the data, there is no any difference in terms of efficacy. So the efficacy of different route of progesterone is equal. Maybe we can discuss regarding the efficiency and maybe the compliance with the patients, some reproductive outcome can benefit or not by some different luteal phase supplementation. But at the end of the story, I am not able to recommend some specific strategies in fresh embryo transfer. So according with the data that we have, theoretically, the vaginal progesterone is the common route that we use in our clinical practice. This is what we do in our clinical setting. And according with the data, the right time to start with the luteal phase progesterone is the day of the pickup or up to 3 days after the pickup, because we know that after day 5, we have a decline in terms of level of progesterone. And so maybe in the fresh embryo transfer, the optimal range is between the day of the pickup and the day 3. So another question is, when can I stop the luteal supplementation in fresh embryo transfer? Again, the data are not very strong enough to say we can stop when we have the positive pregnancy test. Some data support the luteal phase supplementation until day 7, until 7 weeks, 8 weeks, 10 weeks. Usually in our clinical practice, we support the luteal phase until the 10 weeks. But again, the question is not when, but maybe we need to personalize the luteal phase supplementation according with the patient's characteristic. In this paper coming from Akan, I think it's a very important point, because if you had the vaginal progesterone the day of the pickup, we have a sharp increase of the level of progesterone up to day 3. Okay, but between day 3 and day 5, after the pickup, we can have 30% of the patients, we can have a drop in terms of progesterone levels. And the question is, this can be affect the reproductive outcome. And maybe in these patients, we can use a personalized approach. But the question is still open. What can I do? I can add the subcutaneous progesterone. I can increase the vaginal dose, or maybe I can make a freeze-all strategies. But this is just to realize that in fresh embryo transfer with a standard approach, we can have a drop in 30% of the patients in terms of level of progesterone. And the question is, one size will fit all in fresh embryo transfer, or we can use a standard luteal phase supplementation. What we know today is that there is a significant interpersonal variation in circulating progesterone levels during the early and the mild luteal phase in fresh embryo transfer. And the variation is correlated with the bioavailability of the ACG with the quality of the corporal lutea, because not all the corporal lutea are the same, and with the viability of the exogenous progesterone administration. And so many factors we have to take in consideration when we analyze the luteal phase supplementation in fresh embryo transfer, because we know that the serum progesterone level can change if you use subcutaneous or intramuscular administration, or if you use a vaginal administration. And so also, we need to take in consideration that there is a physiological variation during the day in terms of progesterone concentration. So these aspects, I think, are important if you want to know the real progesterone measure in our clinical setting. What about the frozen embryo transfer? Everybody knows that today the number of the frozen embryo transfer is growing over the time for many reasons, because we use the PGTA cycle, because we want to avoid the OHSS, because we want to improve the single embryo transfer policy, you know, when we have a high progesterone rise the day of the trigger. So this is the reason why, of course, the number of the frozen embryo transfer is growing. This is our data. So in my centers, we perform only 20% fresh embryo transfer. In 80% of the case, we use frozen embryo transfer for many reasons. We use frozen embryo transfer, and so the question is, which kind of the endometrial preparation can I use in my clinical setting? Of course, I have to put in the balance a different approach, pro and cons, minimal cycle monitoring. This is, I think, for us a big issue, because we have patients coming from different parts of Italy, easy scheduling, the cost. So anyway, this is what we try to manage everyone during our clinical practice. We have different options, of course. We know artificial cycle with or without GnRH agonist. We can use natural cycle, true natural cycle, or modified natural cycle, or in some specific case, we can add the mild stimulation. The point is that if you look at the international survey, in the majority of the case, the physician use the artificial cycle. It's logical, because maybe sometimes we need to synchronize the time for the embryo transfer. This is the data coming from our center. When we transfer single euploid blastocyst, apparently the endometrial preparation does not impact the live birth. And so the question for me is not which is the best protocol in terms of efficacy, because apparently it works in the same way if you use artificial cycle or if you use modified natural cycle. But maybe the question is the maternal and the neonatal outcome when we use frozen embryo transfer, or when you use natural cycle, because of course many data are in favor in terms of reduce the neonatal and maternal complication in favor of the natural cycle. In particular, when we have, I think, strong data to support that when you use the artificial cycle, we have an increasing risk of hypertension disorder. So we go step by step. When you use the artificial cycle, we need estradiol. Of course, we can use oral estradiol or transdermal. Data confirm that apparently there is no any difference. The question regarding the starting days of the estradiol is not an issue. You can start in day 1, on day 2, on day 3. And if you use fixed dose or if you use step-up protocol, apparently there is no any difference. There is no reason to check the estradiol during the artificial cycle, but maybe the only correlation is that in terms of duration of the estradiol treatment, because if you have a shorter duration of the estradiol treatment, some evidence support that you have a small increase of the miscarriage rate. But you can prolong the estradiol administration theoretically up to 28 days. We need to use the ACG, we need to use the agonist degeneration analogous. So apparently in this Cochrane are in favor of the generation analogous in order just to avoid the premature ovulation, but the quality of the evidence is very low. And in my personal opinion, generation analogous or not, I prefer don't use the generation analogous for the artificial cycle. What about the luteal phase supplementation artificial cycle? We can have different options: vaginal, intramuscular, subcutaneous, oral. But the point is that I don't have strong evidence to support a specific strategies to support the luteal phase in artificial cycle, because we have scarce comparative data existing between different route, different dose of progesterone, a different type of the administration. And so apparently these data support that you can use whatever you want, but we cannot recommend a specific strategies. I think the question is, we need to personalize the luteal phase support, or one size fits all. So if you use a conventional approach, is the best way. The personalization may be something that we need to take in consideration based on the interpersonal variation that we have in the circulating progesterone level. But of course, the question is why, when I need to check my progesterone: the day before the embryo transfer, the day of the embryo transfer, or the day of the ACG. And another point is that which is the ideal range of progesterone during the artificial cycle. Because of course, the large variation of progesterone is something that exists in our clinical practice when you use the same dose of luteal phase supplementation. But this is logical because, of course, the uptake, the distribution and metabolism of the progesterone can be vary based on BMI, female age, birth weight, previous birth, low progesterone in the previous cycle. Sexual intercourse maybe decrease the level of progesterone during the vaginal administration, or in specific patients population, for example, patients with adenomyosis. Apparently, you can find many papers with different design, with different patient population, but apparently the correct range dose regarding the progesterone level must be between 8.75 and 32.50 nanogram per ml. And the question is, okay, this is the correct range. What can I do? What can I do to make a rescue? There is any evidence to support a rescue in patients with a low level of progesterone? Apparently, this meta-analysis, this systematic review support that if you have patients with a low progesterone level during the luteal phase supplementation less than 10 nanogram, they can benefit regarding the additional progesterone during the standard luteal phase supplementation. And if you make this rescue, you will have at hand the same reproductive outcome. Of course, when you look at the meta-analysis, you can see different heterogeneous patients, heterogeneous also setting. Of course, this is not maybe a strong data, but I think this is something that we need to take in consideration. The Brussels group proposed to make a rescue with the oral dihydrogesterone, okay, 10 milligram 3 times a day, the oral progesterone. And again, if you make a rescue in patients with, in this case, with a low level of progesterone the day of the frozen embryo transfer lower than 8.8 nanogram per ml, you can compensate, you can make a good result compared with the patients with a normal level of progesterone during the artificial cycle. But what about if I had the progesterone from the beginning, so without monitoring the progesterone measurement during the luteal phase supplementation? This is what we do in our clinical practice. This is the study that we presented these years at the Este meeting. So in patients with worse reproductive outcome, so worse reproductive outcome means patients with advanced maternal age, with a longer duration of infertility, with a higher number of the previous IVF failure, we had the progesterone, the additional progesterone plus the conventional dose. We had the subcutaneous progesterone. And apparently, these strategies can be useful in terms to reduce the biochemical pregnancy loss. There is no difference in terms when we transfer euploid single embryo transfer in terms of live birth, but we have a reduction in terms of biochemical pregnancy loss when we had the subcutaneous progesterone without monitoring the LH. Without monitoring the progesterone. The question is, okay, the overdosing of progesterone can have a negative impact. Theoretically, no. Some evidence support no difference. Other evidence support that we can have a detrimental effect, but I think the question is still open. What about the personalization in modified natural cycle or in true natural cycle? In true natural cycle, again, this is a heterogeneous study, different study design, different population, different stage of the embryo transfer. Again, different luteal phase supplementation. If you had the progesterone in order to support the luteal phase in true natural cycle, apparently some data support the evidence, other data no. This is, I think, an interesting data because it was performed in PGTA cycle. So, natural cycle, they tested the progesterone the day before the embryo transfer. And again, the threshold should be 10 nanogram per ml. So the authors concluded that if you have patients with 10 nanogram per ml the day of the embryo transfer, you will have a lower reproductive outcome. But on the other hand, a recently randomized controlled trial, the retrospective study could not reproduce this finding. And so again, the question for me is still open, because if you look the data coming from when we transfer euploid blastocyst in true natural cycle, apparently there is no any correlation in terms of live birth when we correlate the live birth with the progesterone level. What about the modified natural cycle? Modified natural cycle we trigger with agony, we trigger with ACG, and this is what we do in our clinical practice just in order to synchronize the time when you manage many frozen embryo transfer. I think this is one option. Maybe in the future we will have another option I will present later on. But again, the possibility to use the progesterone supplementation, I think is something that we need to explore. In our clinical practice, we use 400 milligram micronized progesterone to support the luteal phase in modified natural cycle. Of course, another topic is the optimal timing of progesterone initiation, because they open the implantation windows in a correct way is mandatory, it's crucial. And so if you use the ACG or if you use artificial cycle, of course, you can change the time to progesterone initiation. This is the reason why a new approach in order to promote maybe the natural cycle for frozen embryo transfer is to start with a natural cycle, don't wait the dominant follicles, and plan the embryo transfer without wait the ACG. So we don't perform the ACG trigger, and we open the implantation windows just to add the progesterone administration. This is what now we can call natural proliferative phase frozen embryo transfer, NPP frozen embryo transfer. So I think this is the option is very interesting because we can start in the natural way, so without estradiol, and depending if you have a good endometrium and if you want to plan the embryo transfer, if you want to avoid the weekend, you can start with the progesterone and then you can plan the embryo transfer. And the data are very promising. We are working, our colleagues, Samuel Dos Santos, I think will publish it, very soon a paper, but also in our setting, we have a project on this issue because of the question regarding the artificial, the question regarding the endometrial preparation is not because we believe that there is one best protocol. The only benefit is that in terms of try to optimize the live birth, of course, but also try to minimize the maternal and gestational outcome. So this is the reason why the question is still open again regarding which is the best protocol. In fresh embryo transfer, maybe we can check the progesterone because we can have an interpersonal variation, and I can demonstrate that 30% of the patients can have a variation. Not all corporal luteal are the same, and so this is the reason why we can have a huge variation. Regarding the artificial cycle, maybe we can check the progesterone the day of the embryo transfer, for example. And I think the threshold is still an open question. 8.8, 10 nanogram per ml. I don't know. Regarding the personalized approach in natural cycle or modified natural cycle, maybe we don't need the supplementation according with the evidence. And so maybe the new protocol can help us to try to improve the safety for our patients, but also improve the possibility to plan the embryo transfer according with our setting. Thank you very much.